One gentleman, the last gentleman that I treated, had ischemic foot pain. I saw him last in the hospital about 5 days ago, and I performed a interventional injection, a lumbar sympathetic block, to try and improve the blood flow to his lower extremity. This particular patient's 85 years old. He's had open heart surgery. He has a pacemaker. He's not a candidate for surgery to improve his blood flow. He's also not a candidate for interventional therapy by radiologists to place stents to improve his blood flow. After I performed his injection last Friday, I saw him on Saturday morning. He had marginal improvement. In Europe, a lot of spinal cord stimulation therapy is done for vascular insufficiency like this gentleman has. So I spoke to his surgeon, I spoke to his primary care doctor about trialing him with spinal cord stimulation therapy. And in this office today, I performed that. At the conclusion of the procedure, after I placed a single lead spinal cord stimulation lead in his thoracic spine, he had stimulation down the entire length of his right leg all the way down to his ankle where he has pain. So our hope is with this gentleman that he will have coverage for his pain, and he certainly did at the end of the procedure. He will leave this device in temporarily for a week. He'll come back at the end of that time. We'll determine if he's a candidate for permanent implantation of that device. Temporarily, again, the initial outlook is good for him. It would be great if we could salvage this gentleman's arterial supply to his leg. The reality is that if we don't do this, if there's not any other good options for him, the fact is with a lack of blood flow to his leg, he most likely will develop a skin ulcer, which would lead to an infection, which would lead to an amputation. So again, being sort of a last resort for this gentleman, we're very hopeful that it will cover not only his pain, but improve the blood supply. Mr. Thomas was a patient I first met just about 5 days ago in the hospital. I was consulted on him to see what I could do for his improve his blood supply in his leg. He has a known history of peripheral vascular disease, and in the hospital I did what's called a lumbar sympathetic block or lumbar sympathetic injection to try to increase the blood flow to his right lower extremity where he has what's called ischemic pain. And that injection I did Friday, again 5 days ago. I saw him the next morning, and it marginally improved his condition. He's seen a surgeon as well as interventional radiology. There's really not a good surgical solution for him. So my hope today is to put a stimulation lead in his lumbar spine, lower thoracic spine, and to go ahead and cover his pain pattern down his right leg. This is done in Europe actually quite a bit for vascular insufficiency like what he has. When they're considered not good surgical candidates. Let's go a little bit this way too, Betty. Other way, I'm sorry, other way. There we go. And again, my hope is that we can get this lead positioned where it needs to be, like I said, to help him with his pain pattern. Looks like he's also had an L1 compression fracture too. I see that. So we'll go up here a little higher. What I'm doing now is just positioning the needle on the entry point in the skin. We're going to put some local anesthetic solution in to numb things up. This that I'm unpacking here, unpackaging, is a spinal cord stimulation lead that I want to place in his spine. And it is a lead with 8 different contacts. I'll show you here those contact points that, again, these metal sites, there's 8 of them on this lead. I want to put that into the lower thoracic epidural space. The other end is going to connect to a generator. An outside generator is going to turn those leads on and give it electricity and stimulate these nerve endings and try and decrease the pain that he has in that leg and also improve his blood supply. What I've done, I've just entered the epidural space using what's called loss resistance. And I'm about 90% sure I'm in the epidural space. What I'm going to do now is try and thread this lead to the right position. Again, using fluoroscopy, which is the machine that gives us our image. Okay. What I've done, I've positioned the lead just slightly right of midline at the top of the T8 vertebral body. So what we'll do now is we'll hook up the cable, and the generator will supply it with electricity to see if we can cover his right leg. Now he may get, with this position, he may get some left leg coverage. The problem becomes if you go too far to one side or the other, left or right, you may get some abdominal or some rib stimulation. So we need to be careful not to go too far to the side. So the sacrifice of the price you pay for that, sometimes you get both legs covered. Let's lay this here, Susan. How you doing, Ralph?
Okay.
Alrighty.
So far.
So far, so good.
This is the part where I turn on that tingling, okay? What I want you to do is just to tell me when you first start to feel it, all
Yeah,
right?
say that once more to make sure I heard it all.
You're gonna start to feel a tingling or a buzzing sensation, and I want you to tell me when you first start to feel it, okay? And then I'll turn it up just before it's too strong. And I want you to tell me where that level is.
What I do is before I remove the lead or do anything different, I leave the needle in place. We test it where it's at because I can make position changes with this where it's at. And we'll find out now if we've got his leg covered well enough, and I'll move it up or down accordingly.
When you feel it.
If I'm going to touch you back here, do you feel tingling where I'm touching your bottom? Does that tingle?
Right now?
Right now, huh?
Yes, it does.
In other words, what I'm going to do, Ralph, is I'm going to touch different parts of your body, and what I'm trying to find out is it tingling where I'm touching? Do you feel tingling where I'm touching? So if I touched you up here, you're probably not going to have any tingling from that device.
Okay.
But if I touch you down here in this area, you feeling tingling where it's going on? Okay. Do you feel it down this right leg?
Yeah, I do.
Okay. Do you feel it in your calf?
I do.
Okay. It tingles. Is this normally where you have your pain in this right calf?
Not really, down.
More in your.
Pain is more towards the ankle area.
Okay, down in here. Do you feel tingling down here yet?
Yeah.
Okay. So do you feel tingling down here in your lower leg where you normally have pain?
Yes, but
Not real strong.
the tingling still has not reached the ankle area where.
Okay, we'll make some adjustments. Do you feel any tingling on your left side at all?
Yes, I do.
Okay, but it's more on the right? Okay.
More on the right.
Yeah, let's say you're probably going to get a little bit on the right because we're close to midline, but that's to get good coverage on the right, you'll probably have a little bit over here on the left side. Susan's going to talk to you some more here.
I'm turning it back up again. You tell me when you
So what
feel
we've done is we made a change with the pulse width or rate, that we've moved the lead contacts, making different ones positive and negative, trying to get it driven down to his ankle where most of his pain is.
Yeah.
Okay, good. I'll start here again. Is that tingling in your bottom?
Yeah, that's a strong pain.
Strong there. Okay. Do you have any tingling up here at all? Maybe a little?
Some, but
not much. Okay, stronger down here then. How about your thigh?
Oh, yes.
Strong there. How about your calf?
The calf is in there, yeah.
Okay, is that tingling?
That's tingling.
Okay, how about this ankle?
Yes, right in there.
Okay. Now, is that where you have most of your pain?
Yes.
Okay. Is this better coverage for you where you were having pain? Does this tend to make it tingle or feel better where you've been hurting?
Yes.
Okay.
So you are feeling tingling in your ankle that you normally have your pain in?
Yes.
Okay, using 6.0. What did you do different? You brought it down?
Yeah, you want me to go to the bottom and try
Yeah,
that out?
let's see how much room we have. What we always do when we put these in is that we want to have good coverage with basically the middle 2 or 3 leads being functional. And if we find the very bottom of the lead is the one that is working, I may try and pull the lead back or move it up if it's too high, trying to make sure it centers. That way, if the lead moves some during this next week of trial, we've got some room to manipulate the contacts and program them differently.
Okay, tell me when it starts to get too strong.
That's it.
Right there?
Pretty good there. I'll touch your on your bottom here again, Ralph. Is this tingling here again? So what we're determining is that we use the bottom 3 contacts, and we found that it tends to focus more of the stimulation away from his bottom and kind of get it down here where he's hurting more. The problem with that is that we're at the very bottom. I'd rather have the lead maybe move down a little bit where we can adjust the up or down on the programmability. We're also now testing the very top 3 leads to find out if he gets good coverage up there. So all these things need to be done while the needle's in place, and we can make adjustments through the needle. Once we get it properly positioned, we're happy with the position on the screen and programmability, then we'll take the needle out and secure it.
No.
Okay, all the way to the top. Okay.
Anything?
All righty. Okay. So what we've done, we've moved the contacts all the way to the top, the top 3 leads, and we've turned them on. We've turned the power all the way up, and he really has no stimulation. So what I need to do is I need to move this lead down a centimeter, a half inch or so, and see if we can't get kind of the middle of the array being the best coverage. Do you feel tingling here? Okay. How about here? This right calf? Some. How about the ankle area?
I'm feeling the ankle.
You can feel the ankle?
Yes.
And this is where your worst pain is?
That's it.
Okay. And your calf doesn't hurt you too much?
No, not too much.
Okay. So the ankle is that where you have your worst pain, it feels like it's tingling?
That's right. Just
okay.
Slightly north of the ankle.
Okay. And you're covered there. Now your left leg, we haven't talked about it. You getting a little bit on the left side? Not too much?
Yes, a little bit.
A little bit, but it's not bothersome.
No.
Okay. All right. I think we're good. Okay. All right. Let's yeah, we'll just save that'll be our save, Betty, and we'll be done. Yeah.
Good job. All right.
It went very well, Ralph. Yeah. So what we've determined, like I say, the initial placement was just, again, a centimeter too high. We moved it down just a touch. And now we have the middle contacts getting his worst area of pain, getting it covered. And our hope is, like I said, over the next week, he'll continue to be essentially pain-free from it, not be dependent on narcotic medications for his pain relief, and use this device. And then if it does give him coverage, like I say, he'd be a candidate to go ahead and have the device implanted, which would take place in the operating room and on another day.